Welcome to No Way But North, where we talk about the miracles of recovery and the tools used to achieve them. My name is Cooper Lyons. My clean date is November 27, 2010, and I am your host. As always, actually not as always, I've been gone a couple episodes, so I can't say as always now, but I'm joined by Big John Meldrum. You know him as Big Brown Chocolate Bear.
Nobody calls me that.
I really want it to be a thing.
Nobody calls me that. I mean, I've been gone for like 2 episodes, and realistically, I've only been gone for like 1 day.
Yeah, I know, but one day feels like forever when we're doing these.
Whatever.
And you know it does.
No, it doesn't.
It'd be really easy to
Listen,
that
you can't. I just got back from vacation. You can't bombard me.
That's
with
the
this type of
perfect time
harassment.
to bombard you. I gave you a hug and said I love you and I miss you.
I don't love you and I don't miss you.
Yes, you did.
You cut my
Anyway,
music short.
guys, thank you for joining us. As always, if you get anything out of the show, please hit that like button, that subscribe button. I'm going to harass you again about it by the end of the show. But for now, we're going to jump into it. Our guest today is Amy Hauser. Amy is a Sidney, Nebraska native. Actually, no, I got that wrong, didn't I?
No, it's
Didn't you?
correct.
Is that right? Okay. Is a Sidney, Nebraska native that has found a home in Boise with a Bachelor of Arts, double majoring in both psychology and sociology from Cornell College, as well as a master's in counseling from Idaho State University. Amy has worked in and around addiction and mental health treatment since 2010, and even went as far as the saintly choice to open a Medicaid clinic. Amy has also worked in the Boise State Counseling Center as a crisis counselor and in the prison system. When Amy isn't fighting with insurance companies for our patients as a utilization review specialist, she's kicking ass in roller derby or headshotting her coworkers with Nerf guns. You will see Nerf guns on the table during the episode. John might try to steal mine and shoot me with
Wait,
it.
you do roller derby?
Oh, yes. I used to play, however, I'm coach now.
Oh, really?
Yes.
When did that? Is that a new thing?
No,
Takes a
since I've been
unique
with
soul to
Northpoint,
coach.
I've always coached, but I think last 2 seasons I've been retired.
Okay.
I retired once early for
feel
an
like we've had
ACL
this conversation.
surgery, and then I came back for the one last season to make sure my knee wouldn't like blow up if I fell on it, because that was a thing in my mind
So
at that
you
point.
to test that your knee wouldn't blow up, you did roller derby.
Well, I went back for one last season,
Okay.
but I tore my ACL doing roller derby.
Okay.
I feel like we've had this conversation before.
We have. How funny is that?
Just
Your memory is so poor, like normal.
You know, it's still I'm vacation brain right now.
You're just coming back to it.
You know what? It was a great vacation, but I'm so glad to be home.
Yeah?
It's not a vacation when you have 3 kids.
I bet. Nice.
And I have a hole in my lip too. See, I'm just all over the place.
All right, guys, before John spills more water on himself, we're going to get to the quote. Emotional pain is not something that should be hidden away and never spoken about. There is truth in your pain, there is growth in your pain, but only if it's first brought out into the open. Stephen Aitchison, and I hope I'm saying that right, Stephen, wherever you may be. What comes to your mind when you hear that quote, when you gave me that quote, what were you thinking about?
Well, today we're going to talk about co-occurring disorders, and that doesn't get talked much in anywhere. And so when it comes right down to it, unless you talk about what you're hiding and what you're trying to cover up, you don't ever truly heal. And so that's what kind of came to my mind when you asked me for a quote, and I saw that one. I was like, that's perfect.
Yeah, no, couldn't agree more.
You're gonna have
It's
to
like
read
you
it
never
again.
left. Have to read it twice for him every time.
Or 3 times.
Or 3 times, 4 times at this point. Emotional pain is not something that should be hidden away and never spoken about. There is truth in your pain, there is growth in your pain, but only if it's first brought out into the open. Stephen Aitchison.
Stephen Aitchison.
Aitchison. Stephen. We'll go with Stephen.
Definitely got to look at it as not holding things in, definitely letting that out. When we start talking about co-occurring disorders, mental illnesses, a lot of times we see a lot of unfortunate situations where people end up taking their lives and not getting the help that they need or they deserve because they're afraid that there will be repercussions for them being honest about what they're truly feeling and things of that nature. So, yeah.
Yeah, I mean, for me, all I can think about is if you can't share the problem, like if I don't tell a doctor that my knee hurts, I won't know that I need ACL surgery.
Right.
Too soon.
Too soon?
Too soon.
No, I'm good.
Doesn't hurt.
Can't feel anything down there anymore either. But,
Too soon for me.
Why?
It's fine.
You really are in vacation brain right now. But yeah, you can't work on the problem if you don't tell people what it is. You need to tell an
Right.
expert or tell somebody and be able to communicate through that. So Perfect. So I know one thing we wanted to talk about was what utilization review is, what your
Yes.
job is. There's a lot of people behind the scenes in any healthcare company, or public or private, especially at Northpoint. So you're one of those people that is really driving the whole machine from behind the scenes. So we wanted to give you a chance to kind of talk about what utilization review is. John and Amy have a very interesting work relationship.
He's just mad because I yell at him all the time over
does.
email about stuff that he should be doing, that I need done, that needs done like yesterday, but now it needs to be done.
You don't
right
really
now.
have to yell at me that much anymore, though.
True.
I bet you had to love him
True.
so much when he first started.
Oh,
though.
heavens.
I
Heavens
was,
to
I was
Betsy.
still I was still training.
I'm pretty sure I remember our VP saying he's in the bathroom and she's knocking up, you have a UR email, you need to answer that. Please get out of the bathroom
That-
and go answer your emails.
That
remember
100% sounds like Lopez.
I don't remember that.
Yes, I do. 'cause it was really
Conveniently
funny.
don't remember that.
Nope, don't remember.
But utilization review, like I didn't even know what it was and when I first heard about it. And then once I realized what it was, I was like, oh, I've been doing this because, having a Medicaid agency, you're having to, comply with the regulations that they have in order to have a patient in services and, make sure that they are up to code and following everything and still requiring that level of care. And so I had been doing it. I just didn't realize it had an official name and a title. And so when I started at Northpoint, it was very interesting to realize how many people are involved with just insurance billing, chasing claims, making sure that the patient's insurance will cover their stay or cover days. It's amazing how many people. I think we have 4 people working on claims after we've submitted them just to make sure that the insurance will pay. And then just myself and Tom Hammond, I know that you guys did a session or an episode with him. Just him and I do all 5 facilities as far, or are we at, right?
Yeah, you're right.
We
I
have
forgot
5
those 2 Ashwoods for a second.
5 facilities within Idaho and Washington. We do all the prior authorizations and then continued authorizations through that. And people think, even our doctor thought at one point that since we're a 28-day facility, we just have to get one authorization, we're good to go for that 28 days. That is not true, and that's why I email Jonathan all the time about getting me information that I need, because what Tom and I do is we go to bat with the insurance company reviewer as to why that patient needs to be in treatment, why they continue to need to be in treatment, and what the risks are if they were to have to leave early if the insurance didn't want to pay any longer.
Yeah.
And so it's a tough job, and it's a day-to-day, it's a daily fight that we have, and it's all because we want our patients to get the best care possible.
Well, yeah, I think it seems like half the conversations that we have in our tactical meetings, things like that, are about ways that we can make sure that the insurance is paying for their patients. Or our patients, I guess. So.
And just that our clinical is the best that it can be. I mean, because that's what it comes down to is, I've had a few insurances call and say, you know what, this is the best clinical I've seen, and I do the entire Western region. And that's what is prideful, that we are doing the best care possible for our patients. And that's why we strive in emailing Jonathan and all the other facilities all the time is this isn't good enough.
Yep.
This needs to be better.
I was gonna say all that yelling at John pays
Yeah,
off.
yeah. He loves it.
Hard eye roll.
Hard eye roll.
Hard.
He feels a nice palpitation in his chest every time he
Hard.
sees my name.
I like
I just know it.
I just shut her down. It's already there. You
He's
look hard enough.
actually what he says is, Daniel, you need to email her back so I don't have to.
Yeah.
That's what
Which
it comes
Daniel
down
is
to.
going to be the next guest that
Yes.
we have for
Yes.
Northpoint. So we're looking
Today?
forward to seeing him. He's going to be the next guest.
Oh, cool.
So we are, like Amy said, going to be talking about co-occurring. And like Amy also said, is it's not really talked about anywhere, which blows my mind because of how common and often co-occurring disorders are seen, especially within substance abuse. It's very, very rare that we see somebody with substance abuse that doesn't also have some other co-occurring disorder.
I mean, I think you and I talked, prior to doing this, that you'd only encountered one person that truly just was strictly substance use and no mental health issues whatsoever. And I read probably 80% of the patients' information as they come through our facilities, and I would say 95% of them have some kind of trauma or mental health, whether it be just anxiety, depression, grief and loss,
Bipolar.
schizophrenia, you name it, 95 of them have something going on. And like I think we talked about before too, it's the chicken versus the egg, which one came first, you know? Was it the substance use or was it the mental health? And in the end, they exasperate each other.
They play off each other.
And it's our job as, you know, a facility to try to figure out, you know, how to get them both under control. And I think that's what we do very successfully, because there's very few facilities that will treat both mental health and substance use.
Co-occurring at the same
Yes.
time, right? They might do separate things,
Right.
but yeah. That was kind of my next question is, what is the importance of treating both of them at the same time? How does that treatment change?
Sure.
Things
Well,
like that.
I looked up some numbers, and I found on the internet that 20.2 million people have experienced a substance use disorder, and only 3 million of those have encountered co-occurring treatment.
That's nuts.
And in my experience, that 3 million is very underrated, because I'm seeing 95 at least % in our facilities that have mental health concerns that need to be addressed. What was your question again?
Well, so how does that treatment change? So basically, for those 19 million people that aren't getting the co-occurring treatment, how would their treatment change if they were getting that co-occurring treatment?
Well, I think that maybe Jonathan can speak to this, because he works in the facility as far as, you know, the actual treatment. I can speak to what I read.
You do, yeah. We do the footwork. You just read it.
Yes. I will give you that.
You know,
Interesting
it's a fine line, definitely, when dealing with mental health. You know, we have patients come in, there's a lot of evaluations, there's meeting with psychiatrists, there's meeting with the providers, you know, going through their medical history, going through their psychological history. You have this whole process, and we have to pinpoint things along the way to figure out how to work with them out. So, you know, we'll have a patient come in, man or female come in, we get them admitted, we go through this, nursing goes through their thing, counseling goes through their thing, and we start picking up on the different disorders. You know, it's hard to diagnose somebody with bipolar bipolar disorder, fresh off of meth, because they look very similar, right? They'll have manic episodes coming off of meth or any type of amphetamine or any type of stimulant. So Northpoint, the facility that I oversee, you know, it's stabilizing them, getting them off, detoxing them, getting them healthy. A lot of the co-occurring disorders and education will come after they leave Northpoint, because it's really hard to diagnose somebody with something. People may come in with a prior diagnosis, but a lot of times that's just depression.
Based off a 15-minute.
Yeah.
Well, it's
Because they went to see their PCP,
Yeah, they went to
because
go
their
see their
family's
primary
concerned
care.
and they don't want their family to know they're using.
Yeah,
so
so
they
it's just
ahead.
like, oh yeah, well yeah, I have these moments like where I'm super happy, and then like I'm super sad, and they're like, oh, you must be bipolar, and they're like, oh, well, I've been shooting at meth for like the last 6 months. Right, so
day.
they come in, they get clean, and then those things can get diagnosed after they leave.
There are truly people that, you know, legitimately have those mental health diagnoses coming in, but again, it feeds into each other, and so the chemical dependency makes the mental health worse, the mental health makes the chemical dependency worse, and so it's a vicious cycle. And so as we're trying to calm one down, another one will flare up.
Yeah.
And so, but then, you know, it's just a constant trying to balance the beams on those and trying to figure out what's going to work best. And they're in those moments of detox and withdrawals, and it's hard to find out, you know, is this a withdrawal symptom or is this a mental health symptom?
Well, and so to sum that up, it's that you're constantly reassessing. You're taking the time and looking at the entire person, not just a 15-minute window of what they're telling you.
Right.
You're looking at their behavior, how they're acting in groups, how their behavior is changing throughout those groups, and all of those things, and then adjusting the treatment plan as needed.
Yeah.
Is that an easy way to say that, or am I missing a part?
Yeah, I mean, it's an easy way to say that. You know, we're constantly
oversimplified.
we're constantly reassessing and going over it 10 times over. You know, you might meet with somebody and they'll be like, you know, yeah, I've never experienced depression before, and then week 2 they're like, man, I'm so depressed right now.
Yeah.
And then it's like, okay, what's changed since last week? Oh, you got off detox. You haven't drank alcohol in, you know, a week and a half now. So.
Or you got a phone call and your environmental stressors are starting to kick
Yeah,
in because
right.
you've been in a protective environment now. You got, you know, some of those aren't on the forefront of your mind right now, but then all of a sudden you get a call or you call family and all that stress is right back, and it's like, they don't know how to handle those stressors with healthy coping skills. Their coping skill has been to use. And so now we see those fluctuations. And the great part about my job is I get to see it all in the big picture, because I got nursing notes, I've got the counselor notes, I got the doctor's notes, I got text, tabs as well. I mean, so everybody's collaborating on this, and it's a wonderful thing, because you have somebody manipulating the nursing staff. Well, the notes are right there. Counselors can look at it and be like, well, let's talk about this. This is a situation. And so we start to see those patterns. Now that they're substance free and starting to deal with those stressors, okay, now we know how to figure out how to build your relapse prevention plan a little bit better.
Yep. Well, just it's treating the whole person, right? Not just their addiction or their disease, but like what stressors are going on, the things that happen in life when you're like a functioning member of society.
Yeah.
It's financial and family and physical health and all of those things. So okay, perfect. I thought you were gonna say
For
something.
sure, bro.
So how does that usually affect prognosis? So versus, I don't know if you might have a statistic or just personal experience on how well somebody does when they're treated for just one singular thing versus co-occurring.
Sure. Well, I think I don't have any specific statistics, but I would say that they go hand in hand. Like I said, it's hard to say what came first. Did the mental illness come first or the substance use? And that varies depending on the person. That varies on external factors as well as internal. What are your genetics like? What is your family upbringing? What external stressors are you, having on a day-to-day basis? And so what I see is that people go into treatment for just chemical dependency. Okay, that's fine, but are they addressing the mental health piece that's feeding into why you were using in the first place? When you experience anxiety, when you experience depression, or you have, a minor setback in life, do they have the skills to deal with the mental health side of things, or is it just chemical dependency? And the same thing with mental health. It's pretty rare. So what I also see is that, spouses will be like, you're drinking too much and you get out of control. Okay, well, I'll go see a counselor if that'll appease you. And so that oftentimes, from my experience as a counselor for mental health, I have a lot of patients come in for those initial consultations of, well, my wife says I'm drinking too much, but that's just her. Like, that's not true. She's blowing things out of proportion. It could be either spouse, either gender, or family members, but they're really just coming in to get somebody off their back. Are they really coming in to work on their mental health? No, because they've convinced themselves that they don't have a problem because they've used those substances to mask all of those problems. And if we talk about those problems, then it's a problem. But if you just hide it and you pretend it's not there and you cover it up, then it's not a problem. And so I see, it really is something that needs treatment on both sides.
Well, and then if you don't treat one or the other, then, if you just treat one and you don't treat the other, then the recovery is not going to last.
Correct. You have way higher risk of relapse because you haven't dealt with the core problem.
Yeah.
And there's a main reason why you started using substances, and you didn't get rid of that, and so it's going to come back.
Yeah.
And that's just my opinion, but
no, your expert opinion.
Yeah.
So the next thing I kind of really wanted to talk about, and again, you said we weren't going to go on this tangent, but with you two, it's going to happen, and I'm glad for it because it's always an interesting conversation. Ooh,
Like the Matrix. Did you see
shots
that?
Poor Cooper didn't see it coming.
I didn't. I saw the click and I was like, oh God. I didn't know it was going to be me or him.
Cooper's got some PTSD from coming over to the administration office.
Yeah, every time I walk in there, I just get nailed in the face.
It's true.
But I did want to talk about, because just the sheer amount of, or the sheer amount of not talking that happens with, I don't know the best way to say that, but the silence around co-occurring. What is the effect on society, right? So you would know better than anybody with a Medicare, thank you, facility, and then also working in the prison, and then also working on a college campus, right? You have a really good idea of if we really took co-occurring in a national spotlight or more the national mental health spotlight, what kind of things would happen, what kind of things would change. So starting with the prison system, what kind of co-occurring things happen there? What kind of treatment would you see would need to change? Things like that.
Sure. Well, my role at the prison was a mental health clinician.
Hug
That's
a
what they
thug.
call that. What? I'm sorry?
Hug a thug.
Yes, we are definitely perceived as the easy go, or the easy, what do you call it, this easy spot. Like, oh, if I need in-house meals, just go talk to a clinician. Or if I don't want to do something, go talk to a clinician. They'll give me whatever I want. So officers or the law enforcement side, like Meldrum here, don't like us clinicians.
Oh, that's not true. You just made it difficult sometimes.
Well, however, us clinicians also feel like law enforcement makes our job difficult because, as is customary out there, what do they call it? It's not convenient. Security is not convenient,
Yeah.
and so security trumps all. So
Yeah, but look at us now, though. We're on the same team.
yeah, but you don't like me.
I love you, Amy. I always have a don't.
It's a love-hate relationship.
I love you.
Anyway, my job was I had a caseload of inmates where I worked was the behavioral health unit, and that's for inmates who couldn't necessarily live in general population because of mental health issues or maybe some, just oddities that would cause some safety concerns. And so we had that unit. And so my job was to meet with these individuals on a weekly, bi-weekly, monthly basis, depending on their level of care. And so other job was also to assess every inmate who came in with any kind of mental health meds from Ada County Jail or any kind of facility prior to coming into prison, and assess whether or not they needed to see the psychiatrist for continued medication monitoring.
Okay.
And so you get a lot of that problem out there as far as misdiagnosing of bipolar as well, because they've just come out of jail, they're freshly clean, so to speak, we hope, of substances, and they're having some major mental health concerns.
Yeah.
Sometimes they've tripped into schizophrenia, schizoaffective disorder, where they're having a lot of difficulties with auditory and visual hallucinations. And here you are in prison setting with a bunch of other inmates who have no idea why you're weird or why you're experiencing these concerns.
Or don't care.
Right. And so it's a matter of safety concerns, and so we evaluate. And so my other job out there was to evaluate all the suicide assessments. So our unit also housed, 4 suicide cells. Mm-hmm. And so anytime anybody on the yard claimed they were suicidal or were, what are the circumstances, clinician would evaluate them within the first 24 hours, evaluate their risk level, whether or not they were or were not. Oftentimes we have to keep them for several days, sometimes weeks, depending on the circumstances. And in the end, it's hard because sometimes we find out later that they just owed somebody coffee and they didn't have the coffee to pay up. So they ended up on suicide watch to, buy themselves some time until somebody could put money on their books. Or they were truly having some difficult time mental health-wise. But the amount of people out there with substance use and mental health concerns is astronomical.
Yeah.
So coming back to the co-occurring, it's amazing. Like you said, if we could do a national thing on co-occurring instead of just focusing on substance use or just focusing on mental health, we could make a lot of things happen.
Yeah, so what would those things be? Like, if you had to name the top 3 changes that you would see in the prison system when it came to mental health and co-occurring.
We'd probably see fewer inmates.
Okay.
We'd probably see more programming geared towards that, even out at the prison in the community. I think
some more rehabilitation
Absolutely.
Programming than incarceration.
What would you see on the correctional side of things?
If we increased more awareness,
Co-occurring?
You'd probably see a decrease. I think it's hard because I know substance abuse has probably taken off in the last 15, 20 years as far as education and the amount of empathy that you receive from people within society for being addicted to substances. There's still that really hard taboo. The mental health is such a taboo subject still to this day. And so I think if we were able to take the co-occurring disorders, and we were able to educate and really get that out there, and we had as much awareness with co-occurring disorders as we did substance abuse, I think you'd start seeing a lot more leniency when dealing with people within society, right? You get
Alternative sentencing.
Yeah, alternative sentencing, people, getting in trouble, and it's just like, oh, well, let's do a full psych, evaluation. I mean, at times you're going to see, the good and bad of that. Like, people are going to try to manipulate the system and things like that. But I think it would help society that we could actually, if we knew how to treat the individual and their mental health correctly, then the sentencing wouldn't be, oh, you've got 2 years fixed, 15 indeterminate. You've got to go do the 6-month rider, because you put a schizophrenic in a cell, right? They're never going to be successful, right? They're never. Or, if you sit there and you punish or you hammer somebody and they don't understand why they keep engaging in this kind of behavior, but, something's off in their brain, then we're not helping them out. We're just...
Yeah. And we have medication assistance out of the prison. We have the counselors available. We have, limited programming as far as mental health. But at the same time, it's not working.
Yeah.
We're doing the best we can, and the same thing kind of applies to college campuses. A student
And
gets
treatment centers.
Yeah,
Sorry,
and treatment
go ahead.
centers. A student gets in trouble for being drunk or some kind of substance use. You have to go for a substance use evaluation. Well, there's a little bit of mental health evaluation in that, but it's mainly focused on substance use education. It'd be interesting to see what would happen if we tried to develop more of co-occurring education. They're trying very hard, but it's tough.
Yeah.
But in treatment centers, I'm biased, and I think we do the best job out there. And I know that we do both co-occurring, the mental health and the substance use. When I try to look up other places that do it around here, it's hard to find anybody that advertises co-occurring disorders. It's mostly just one or the other. And honestly, mental health clinicians, counselors, unless they've gone out and done training on their own, aren't equipped to handle substance use.
Well, that was another thing I was going to ask about, is what's kind of taught about co-occurring when you get into counseling courses or social work courses, and the master's level, right?
Right. I can speak from the counselor side. I'm not so sure about the social workers, but I know we get a class, maybe 2, on substance use and how that's handled as far as mental health. But it really gives you the basics, and it's on your own to go and do that continuing education. And especially, if you find yourself in a mental health clinic and you're seeing a lot of borderlines, well, you're going to want to go do some more education on borderline personality disorder. But if you don't work in chemical dependency, you don't really have that drive or that motivation to go learn more about it unless you start seeing a lot of people coming in for that. And they're usually those patients, like I said, that are coming in just for that consultation to get their family off their back, and then they never come back.
And they're blaming it more on something else,
Right.
and downplaying the substance abuse. And if
Correct.
you're unaware of that, you haven't had that substance abuse
Right.
training, you're not going to know how full of shit an addict
Right.
or alcoholic is.
Exactly.
Yeah.
Whereas, I have more mental health background, where, Meldrum's got more chemical dependency background. So, what kind of mental health training do you get in your chemical dependency?
Not a lot.
I love how I just changed that over, and Cooper got really excited about that. Well,
I'm gonna shave your
we hadn't
beard.
thought about that.
No, I think you're a very intelligent man, and I like it when you talk about all these things because you're very knowledgeable.
Well, and that's a big thing, right? Is when we're doing, for my certification for CADC, you have we can't diagnose anything mental health, right? So when I'm assessing a new patient, they're coming in, I'm only diagnosing them based off of what they're telling me they've been diagnosed in the past. So if they've gone and said, yeah, I went and one of the questions is, have you ever experienced any mental health disorders? So I'll ask them, have you ever been diagnosed with depression? They're like, yeah. I'm like, so you went to a doctor and a doctor said, hey, you're depressed. This is medication. Yes. Okay. So I can diagnose that. Anxiety. If they say, I think I'm bipolar, I can't diagnose that. But if
Or if they tell you all the signs of being
right, I'd be like, okay, that's fine. We'll have, you'll be meeting with the provider, you'll be meeting with the psychiatrist, and you guys can talk about that more in depth. But I've had patients come in, and they're like, yeah, I'm bipolar. You've been diagnosed? Yeah, I went to the doctor, and the doctor diagnosed me bipolar. And I'm like, okay, but your primary drug is meth. So I'll put that down, but I'll make a note, like, hey, they've been diagnosed with bipolar disorder while they were using methamphetamine.
Which I think is partly because of your CADC training, but then also your time out at the prison, right? And seeing all the mental health that was out there. Do you think that's fair to say?
I mean, yes. I would say it's a combination of what I do now. The time I spent out of prison, I did do some case management at the prison. So, like,
Call a clinician.
I was called a hug-a-thug at one
Call a
point in time.
clinician.
But yeah, so I did some case management. I did some programs out there, but I mean, Amy's absolutely correct. Like, you know, if I'm looking at a situation and I see somebody, I'm just like, oh, like, it's not like I'm like, oh, they have bipolar. I'm like, oh, they're acting fucking crazy.
Yeah.
Like, we need to secure them right now before this turns into something bigger, and then we'll deal with it later. I would say another area of, you know, just understanding what mental health looks like is not only with my career now, the prison, but also with the stuff that I do with the NCAA as far as collegiate mental health as well. So it's kind of a wide range of things that you see. I've been doing the collegiate thing for about 8 years now, just making mental health awareness more prevalent within college sports, because that's something that's really neglected.
Yeah, and nobody wants to talk about it in sports because they don't want their
Shut
eligibility to
up
play,
and dribble.
you know, to be affected. And, you know, if they're foreseen as broken, I mean, that doesn't play into their
NCAA
ability.
has the right to take away your scholarship if you were deemed mentally unstable to go to school.
So it's
That's terrible.
nobody talks about it.
Yeah. So take us out of here with what should be changed. We kind of talked about, you know, awareness always with every single cause in the world. Awareness is always the answer. But what kind of other things could somebody listening right now, or me and John for that matter, what could we walk away from this table with and change and be to affect some change? Does that make sense?
Yeah, I think it goes right back to that quote. If you don't bring it out into the open, you can't work on it, and it can't be helped. You can't solve what's going on with you unless you talk about what's going on inside of you.
Yeah.
You know, if you're bothered by something, if you have anxiety, if you're using substances to manage symptoms, talk about it. The more you talk about it, the more you are relieved and free of that burden to be able to do all the things that you want to do that you stop doing because you're so consumed with substances at this point, and, you know, feel happier. I mean, that's the thing that, you know, I see a lot of in the assessments is I'm not happy, and I want to be happy again. I used to be happy, and they've lost that, and they've lost the hope that they can be happy again. And I've seen a lot of people graduate who are like, once I started working on all this, I finally was able to find some happiness and some
Might
relief.
have taken a minute, but
Yeah, just, you know, talking about the stuff that we're uncomfortable about. You know, take examples from, you know, your alumni groups of people who have done this successfully. Of it can happen. It's going to be hard, but it can happen.
Anything to add?
You got it. You got a girl.
With that being said,
Yeah.
guys, if you're in pain, go talk to somebody. If you know somebody in pain, just go listen. Guys, this is No Way But North, where we talk about the miracles of recovery and the tools used to achieve them. Please don't forget to hit that subscribe button, that like button, and tell one person that you think might get any value out of this. Check us out. We appreciate you. Thanks for joining us.
Peace.
If you or a loved one are struggling with addiction, call 1-877-648-3125. The views and opinions expressed in No Way But North do not reflect those of Northpoint Recovery or any other institution or organization.